Hi, my name is Dan, and I'm a mental health pharmacist, and today I'm going to be giving a presentation on anxiety disorders. So I have three major objectives that I want to cover today. First is I want to identify and differentiate between the different anxiety disorders in the DSM-5. Then I want to interpret some of the risk factors and neuroanatomy involved with anxiety disorders. And then finally, I want to talk about treatment for three specific types of anxiety disorder. So I want to talk about treatment for generalized anxiety disorder, panic disorder, and social anxiety disorder. First, I wanted to start with what the DSM-5 starts with, which is differentiating between anxiety and fear. So anxiety is the anticipation of a future threat, whereas fear is dealing with an imminent threat. So an example is if you go camping, anxiety might be that you might think about a bear coming into the campsite and worry about that and perseverate on that. Whereas fear is when the bear comes to the campsite, how you respond to that imminent threat. And both have advantages as well. So for example, anxiety related to the bear coming into your campsite may provoke you to buy a bear bag and store your food a couple hundred yards away from the campsite and so on. Whereas fear can be beneficial because if the bear comes to the campsite, if you have a fear response, a flight or fight response, you might survive, whereas otherwise you might not have. So they both have evolutionary advantages, anxiety and fear. The issue is when they become prevalent and prominent when there's not a real threat. So what are the types of anxiety in the DSM-5? And there is actually many types. So generalized anxiety disorder is the most commonly thought about type and the most common type of anxiety disorder. But there's also panic disorder, social anxiety disorder. Those are the three that we're going to be talking about the most. And there's even more than that. So there's separation anxiety disorder. There's specific phobias, selective mutism, agoraphobia, so on. So there's many different types of anxiety disorders in the DSM-5. The reason I picked these three to talk about is that they have the most established treatments, the most established therapies. So that's what we're going to focus on and highlight. So that's it. That covers the first objective. I just wanted to set the scene a little bit and show you the different types of anxiety disorders in the DSM-5. And let's go on to the second objective. So I wanted to talk a little bit about epidemiology of anxiety disorders. The lifetime prevalence is 33%. So this is the most prevalent mental disorder in the United States, higher than major depressive disorder, higher than bipolar, higher than schizophrenia, so on. So anxiety disorders are the most prevalent. Next is the average age of onset is pretty interesting. So it really depends on the type of anxiety disorder you're talking about. So specific phobias, separation anxiety disorder, the average age of onset is 7 years old. Whereas generalized anxiety disorder, the average age of onset is 31. So that age has a large spread to it. And a German epidemiological study looked at prevalence rates versus age, and prevalence rates increased until the 50 to 64-year-old age group, where prevalence started to decrease, and then they were the lowest in the most elderly group, the 65 to 79-year-old group. So that means even without treatments, anxiety disorders do not last until old age in most cases. So age is a protective factor for anxiety disorders. Next, anxiety disorders frequently co-occur with other mental illnesses, especially things like major depressive disorder. And according to a WHO study, WHO meaning World Health Organization, only approximately half the cases of anxiety disorders are recognized, and only 1/3 of the affected patients receive treatment. So there's still a lot of work that we can do in treating anxiety disorders. Risk factors are somewhat interesting. So childhood traits of shyness, which makes sense for certain anxiety disorders like specific phobias and separation anxiety disorders, but it's a risk factor for all types of anxiety disorders. Next is childhood stress or trauma and family history, which go hand in hand. So there is a genetic risk for anxiety disorders, and then if there's childhood stress, childhood trauma, bullying, something like that, it can cause these genes, these at-risk genes, to be expressed, and that person shows the signs and symptoms of anxiety disorders. So genetics and upbringing plays a big role. Next is physical health conditions. So certain things like thyroid dysfunction, substance use disorders, heart arrhythmias can all contribute to anxiety. Next is neuroanatomy. The brain's complicated. There's many areas that are involved with anxiety, but I wanted to highlight these four. So first is the amygdala. So this is like the fear center of the brain. Amygdala is Latin for almond. It's an almond-shaped area of the brain, best known for processing fear. So when a fearful stimuli reaches the brain, it goes to the amygdala first. And what the amygdala does is it decides if it should send out epinephrine, norepinephrine for that fight or flight response. After that, before I get to that, one more thing about the amygdala is it has a memory in regards to fears. So there was a study where they played a tone and then administered a shock to mice. And mice with their amygdala fully intact, every time they heard that tone, they would freeze because they knew something bad was coming, they were afraid, and then they would get shocked. And then in the other group, they destroyed the amygdala in the mice. They played the tone, and then they applied the shock. And in that group, the tone meant nothing to the mice. They didn't know that they should be afraid. So the amygdala can also store some of those fears related to what is fearful. So after the amygdala decides if it should participate in that flight or fight response, the signal goes to the hypothalamus, which is involved with the HPA axis. That network consists of the hypothalamus, pituitary gland, and the adrenal glands. And activating that axis leads to the release of cortisol, which is a stress hormone. So over a short period of time, cortisol can be helpful. It lets you know that there's something to be anxious about, something that you should be worried about and take care of. But over a long period of time, cortisol is damaging. It can damage certain areas of the brain. It's not good to have around for a long period of time. So next is the prefrontal cortex and the hippocampus. So both of these acts as brakes on the amygdala. They tell the amygdala to cool it, to slow down. But in some people, there's less functioning in the prefrontal cortex and the hippocampus, so there's less brakes. It allows the amygdala to keep pushing forward these anxiety signals. So all four of these brain areas play a role with anxiety, but amygdala is the general fear response of what people think of first. And the long-term effects of anxiety are interesting as well. So just like how depressive episodes can be damaging to the brain, and schizophrenia can be damaging to the brain, and mania can be damaging to the brain, so can anxiety. And where you'll see this damage often is the hippocampus and the prefrontal cortex, the areas we just talked about. So over a long period of time, the amygdala releases the norepinephrine, epinephrine, the hypothalamus releases the cortisol, and over a long period of time, that is stressful to certain areas of the brain, damages the hippocampus and the prefrontal cortex. But remember, these were the areas that were the brakes on the amygdala, so it's a spiral. The amygdala and hypothalamus overactivation damages the hippocampus and the prefrontal cortex, which can no longer stop the amygdala as well, which further damages the hippocampus and the prefrontal cortex, and it can spiral worse and worse and worse. Also in anxiety, you'll see decreased brain-derived neurotrophic factor, BDNF. And BDNF can be thought of as like a fertilizer for brain cells. It helps them to grow, it helps them to connect. So decreased brain-derived neurotrophic factor is not a good thing. That being said, I don't want to scare you with the brain damage because the brain damage is not irreversible. So remember, the brain's very adaptable, and even in adults in certain areas of the brain, new brain cells are grown and created every day. So a few studies looked at this, and they found that antidepressant treatment and physical activity both increased hippocampal neurogenesis. So it helped to treat that hippocampal damage. So exercise and medications can be helpful in this regard. So there are ways to adapt and prevent or treat that brain damage from occurring from anxiety. Next is pathophysiology. So with our medications, we're not very good at targeting certain areas of the brain. We can't target the amygdala very well, but what we can do is target certain neurotransmitters, certain receptors. So there are a few that are associated with anxiety disorders. First is noradrenergic model. So increase in norepinephrine release is associated with some anxiety, increased acute stress, and then that leads to glutamate release, which is the primary excitatory neurotransmitter. So it will stimulate your brain to fire, which can cause anxiety. The opposite of glutamate is GABA. which is the primary inhibitory neurotransmitter in the brain. So GABA has a strong regulatory, inhibitory effect on other neurotransmitters, serotonin, norepinephrine, dopamine, so on. So this comes into play with medications like benzodiazepines, which are GABA A agonists, so they help slow the brain down a little bit and can help with anxiety. Next is the serotonin model. So greater serotonin activity decreases norepinephrine activity and reduces the HPA response, that cortisol response we were just talking about. So there are some drugs associated with anxiety, and you may be surprised to see antidepressants first on this list. And what is commonly seen is that when someone starts an antidepressant, they feel more anxious to begin with, and then once they are on the antidepressant for a long period of time, their anxiety actually decreases. So at the beginning, they make people feel more anxious sometimes, but over a long period of time, they treat the anxiety. Next, anticonvulsants, antihypertensives can cause anxiety. Steroids cause a lot of issues with mental health conditions, so steroids can cause anxiety. NSAIDs, and then stimulants. So stimulate the brain too much, increase norepinephrine with stimulants, you can cause some anxiety. But it's not just medications themselves, it can also be toxicities. So taking too much anticholinergics, antihistamines can cause anxiety. And then withdrawing from certain substances and medications can cause anxiety. What comes to my head is alcohol withdrawal, benzo withdrawal, benzodiazepine withdrawal. Both can cause anxiety. Okay. So that sums it up for our second objective. So we talked about some of the risk factors. We talked about some of the neuroanatomy. Now I wanted to go into the specific anxiety disorders and how to treat some of them, the three that we're going to focus on. So first is generalized anxiety disorder. And we'll start with the DSM-5 diagnostic criteria. So it's not too surprising that it starts with excessive anxiety and worry occurring more days than not for at least 6 months. So an important part here is the duration. So 6 months feeling anxious more days than not is an extremely long period of time. So everyone feels anxious. It's natural, it's normal to feel that way, but it's when you feel that way for a very long period of time, over and over and over again, that it becomes pathological. Next is the anxiety and worry are associated with 3 or more of the following symptoms. So this is restlessness, feeling keyed up, being easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbance, so on. So you'll see a lot of these symptoms in someone with generalized anxiety disorder. Next thing I wanted to highlight is rating scales. So measurement-based care is becoming really important. So what this means is when you see a patient for the first time, administer one of these scales and put an objective number to their subjective symptoms so that when they come for follow-up visits, you can really nail down if they're actually improving or actually getting worse. If you don't use one of these scales, it can be really hard to tell because someone might have had a couple of bad days and say, I'm feeling much, much worse, but overall you think they're getting better. So if you put in a number to their symptoms, you can look at that at subsequent visits. So measurement-based care, I'm a big fan of. I think it's really important. So some scales I listed here, there's more. The GAD-7 is a short scale, 7 questions. You'll generally see this in like PCP office, like your general practitioners, because it's short and it can let you know if something's wrong or abnormal right away. In psychiatry, I like to use more in-depth scales. So I like this Hamilton anxiety scale here called the HAM-A scale. So it goes a little more in depth, helps me to single out individual symptoms as I treat someone over a long period of time. Treatment guidelines can be seen here for generalized anxiety disorder. So I have the Canadian guidelines, the British guidelines, and then a Harvard project guideline. So what you'll see first line is CBT, cognitive behavioral therapy, and SSRI, selective serotonin reuptake inhibitors. Then, depending on the guidelines and the situation, pregabalin can be first line, short-term benzodiazepine use can be first line, some buspirone, some hydroxyzine. Second line, you generally want to switch to a different first line agent, but there are some additional medications. And then third line would be rarer medications in anxiety, something like a second generation antipsychotic, Depakote, mirtazapine, something like that. But to summarize the treatment guidelines first line, you want to do CBT and an SSRI generally. That's what's most commonly done. I'm a big fan of therapy, so I push that. I really recommend that for a lot of people. So minimal side effects and can be really helpful in treating anxiety. So I push therapy. Medications can also be helpful. SSRIs are generally what's gone to first. Some other first line options, SNRIs, pregabalin, buspirone, hydroxyzine. Second line, try a different first line option. We just talked about this. Third line, you can try some rarer options. So let's go a little more in depth into the medications, and we'll start with the antidepressants. So SSRIs, SNRIs, what you'll see here in the box below is the approved, FDA-approved medications. So you'll see that there's not too many of them. For example, generalized anxiety disorder just has 2 SSRIs that are approved, escitalopram and paroxetine. But what you'll see in practice is you don't have to remain on label. Really, many providers will select any of the SSRIs. This doesn't come into play as much with the SNRIs. So venlafaxine is the one that you're seeing approved the most, with duloxetine in kids also approved for generalized anxiety disorder. But the reason venlafaxine is the most commonly used SNRI is that it has fair serotonin reuptake effects, but it has pretty weak norepinephrine reuptake effects, which can be a benefit in anxiety. So remember, we talked about how norepinephrine can cause anxiety, so you don't want to increase that too much in someone with anxiety. So increasing norepinephrine can be really beneficial in someone with depression where they need an energy boost and they need help concentrating, but you don't necessarily want that effect. In anxiety. Venlafaxine is effectively an SSRI at low doses, and it doesn't have too much of a effect on norepinephrine until moderate to high doses. So that's why it's the SNRI of choice. Generally, for anxiety disorders, you want to start at a low dose. So you start at a low dose in anxiety. Compared to depression, you can start in a slightly higher dose. And then in anxiety, sometimes you need to get to a really high dose. So if you look at it like on a level, you'll see that for depression, you start a little higher, but you can end a little higher. And for anxiety, you start low, but sometimes you need to end a little bit higher. So long story short, since antidepressants can provoke a little bit of anxiety when you want to start at a low dose. Final part about SSRIs, SNRIs before I move on is they take 2 months for their full effect, sometimes even longer than that. So our medications that affect serotonin take months to take their full effect. So it's a good thing to remember. If it affects serotonin, it takes a long time for the postsynaptic receptor downregulation, upregulation changes, all that stuff to take effect. Next is pregabalin. I wanted to talk about this a little bit. This is, remember, first line in some of the guidelines for generalized anxiety disorder. It's a controlled medication, so be aware of that. Mechanism of action, it works on alpha-2 delta subunit of calcium channels, but what that means is that it reduces the release of excitatory neurotransmitters, so it slows things down in the brain. That's how it works as an anticonvulsant, and that's probably how it works for anxiety, slowing down the brain from sending out signals too much. Some counseling points that I wanted to make in regards to it. First is its mechanism. So we just talked about it. Even though it's called pregabalin, it doesn't have direct effects on GABA, so don't associate it with GABA. That's something like a benzodiazepine works on GABA. Next counseling point, suicide. So all anticonvulsants have a class effect of increasing the effects of increasing suicidal thinking. So if you're starting someone on this medication, any anticonvulsant, any antidepressant for that matter, you want to counsel them on if they have increased thoughts of suicide, call their doctor, call their pharmacy, call 911, talk to somebody. Next is dizziness, sedation, CNS depressants. So this is a sedating medication. Again, even though it doesn't bind to GABA, it still slows down your brain from sending signals. You don't want to use like alcohol with it, or opioids, or benzos. So unless it's under the guidance of a doctor and someone's aware you're on these things. So be careful with using too many CNS depressants together. Next is its rapid onset, which is something I wanted to highlight. So look at this study below. comparing Hamilton anxiety scores and someone started on pregabalin versus someone's treated with sertraline, which is an SSRI. You'll see their baseline anxiety scores are similar, but at week 1, people on pregabalin already are 5 points lower in their anxiety score, whereas the person on the SSRI, their score is pretty much the same. So that's one of the biggest benefits to pregabalin or Lyrica, is that it works fast for anxiety. 1 week, their scores are already starting to get better. You don't have to wait that 2 months like you do with SSRIs, SNRIs. Next is buspirone. Mechanism of action, 5-HT1A partial agonist. Remember, 5-HT just means serotonin. 1A is a subtype, so it works on a subtype of serotonin as a partial agonist, so increasing the effects. And remember, again, if it affects serotonin, it generally takes a long time to take effect, and that is certainly true of buspirone. So it takes that 2 months to take its full effect, just like SSRIs, just like SNRIs. It's generally used as an adjunct to SSRIs, SNRIs, and it's important in regulating anxiety, so that's how it works. So they did an animal study in knockout mice bred without the 5-HT1A receptors, and those mice showed more signs and symptoms of anxiety as compared to the mice that had the normal 5-HT1A receptors. So 5-HT1A is associated, plays a role, affects anxiety level. We talked about the slow onset of action, that this works on serotonin, takes months to take full effect. So some counseling points, take it consistently. This isn't something like a benzodiazepine or hydroxyzine that you can take when you need it and the anxiety goes away. It's something that has to be taken every day, multiple times per day. Side effects are generally mild and transient, so you'll see some of the serotonin effects. So you'll see some of the headaches, some of the GI effects, nausea, vomiting, diarrhea. But other than that, it's generally mild. Next is hydroxyzine. Brand names are Atarax or Visceral. Mechanism of action, antihistamine, but also works on a serotonin subtype, 5-HT2, receptor antagonist. And this is one that does work quickly. Effects are generally seen within 30 minutes. So it's something you can take when you feel acutely anxious and the symptoms of anxiety can go away. There's some downsides to it, anticholinergic side effects, so antihistamine side effects too. So it's sedating, it can cause cognition issues, blurred vision, constipation, but it's not controlled or addicting. So it's not something that is like a benzodiazepine that people take as needed, but sometimes that they take more than prescribed, they start to have tolerance, they start to have those kinds of issues. So hydroxyzine is good for the PRN as needed effects, but doesn't have all the same issues as a benzodiazepine. And speaking of benzodiazepines, here we are. First to note, these are controlled medications. They're C4, so they're more controlled than pregabalin. Mechanism of action, GABA A agonist. So benzodiazepines bind to the GABA receptor and allow GABA to bind more easily to open the receptor and slow down how quickly and how often brain cells fire. That being said, it still requires GABA to bind to the receptor for the GABA channel to open. So that's why it's okay. It's a little more safe than other agents that bind to the GABA receptor in regards to overdose, because it still requires GABA to bind to open that channel. Compare that to the older version of benzos, which is basically barbiturates, which work by binding to the GABA receptor, allowing GABA to bind more easily and the channel opens. But in regards to barbiturates, at high doses, it can act as GABA and open the channel by itself. Benzos, no matter what, still need GABA to bind to open that channel. So that's why they kind of took over for barbiturates, which used to be really common, and now benzodiazepines are more common. Final point in regards to the GABA receptor is, as you can see from the little picture here, alcohol also binds to the GABA channel, allows it to open more easily. So benzos are sometimes called and considered a pill version of alcohol. So that's really important to note and to remember. So for example, someone who's going through alcohol withdrawal, they're treated with benzodiazepines. So they don't have seizures, they don't have severe issues because the benzos work on that same receptor. So benzos are generally, for anxiety, good for short-term use. So they help someone for the first couple of weeks while the SSRI or while the therapy is kicking in, and then they shouldn't really be used long-term because of the issues of addiction, tolerance, and some other things we'll talk about later. Counseling points, you really want to let your patient know, take these as prescribed. If you don't think they're working as well and you feel like you're starting to take more, that's something I should know about. That's something you shouldn't be doing on your own. Next is withdrawal. So just like alcohol withdrawal, how that can cause seizures and be fatal, so can benzodiazepine withdrawal. So this isn't something that you can stop suddenly. So let your patients know, if you're running it out, call me, contact me. If something's going on, let me know, and we can taper this over a period of time rather than just suddenly stopping it. Next, CNS depressants. So these are sedating. So be careful if you use them with something like opiates or alcohol, where not only are they more sedating, but the overdose risk goes up a lot if those medications are used in conjunction. Benzodiazepine FDA approvals. You'll see quite a few have anxiety disorder approvals, just 2 have panic disorder approvals, and there's quite a bit without anxiety approvals. So don't think of benzos as having this blanket approval. Some are approved for seizures, some are approved for insomnia, some are approved for anxiety disorders. They all have different approvals and uses. Onset of action is also important to note. So something with a rapid onset of action is really good for seizures. So you want that person to have their seizure go away suddenly. So diazepam has a rectal version that works really quickly to stop a seizure. But rapid effects can be more addictive. So something like alprazolam, brand name Xanax, is known for being abused or used improperly. So you want to pay attention to onset of action. It can help you select the proper benzo for your patient. Next is duration of action. So alprazolam also has a short duration. So it has a sudden onset, so it goes up really high, and then it falls really quickly with its short duration, which is like the worst combination when it comes to addiction. So something that works quickly but doesn't last for a very long period of time is known to be addictive. Think of like cigarettes. The way I remember some of the long duration agent is that they have days in their name. Chlorodiazepoxide, diazepam. So they last for days is what you can think of it. The final component with duration is you have to pay attention to if they have metabolites, which most and many of the benzos do have active metabolites, and then see how long the metabolites last for. So for example, diazepam has 2 active metabolites, oxazepam and temazepam, which are 2 other benzos that you can be prescribed. So something to pay attention to. Next is their metabolism. So most are by hepatic CYP3A4 mediated oxidation, meaning that it's metabolized in the liver. So then you have an issue if your patient's old, which old people have weaker global liver functioning, or if the person has liver impairment, liver damage, liver issues. So if those are the cases, if you have an old patient or a person with liver impairment, you pick a lot drug, lorazepam, oxazepam, temazepam, which are metabolized by conjugation. Sometimes you'll hear people describe this or memorize this as OTL instead of lot, OTL for outside the liver. If it helps you to remember it, that's okay, but also just remember that they're still technically metabolized in the liver just by conjugation, not CYP3A4 mediated oxidation. But that being said, it's less dependent on global liver functioning. So the final thing to note with benzos is discontinuing them. So benzodiazepines were prescribed very commonly years ago, and there's people that are on them for years. And now we know more about the long-term issues with benzodiazepines, and there's been quite a push to get people off of benzos, and it can be hard. Again, we talked before about the sudden issues if you stop abruptly, the withdrawal issues, seizures, psychosis, so on. So you want to taper them over a period of time. There's a few different schedules that you can use. So the first one here is from the VA, from a VA resource. So initially, 2 weeks later, decrease the dose by 25%, maintain on that dose for a month, then decrease by 25% every 2 weeks. Another way to do it, 25% until 50% is reached, dose decrease is reached, and then by 1/8 every 4 to 7 days. Another thing to think about is duration. How long do you want your benzo taper to be? And I found the easiest way to memorize this or think about this is take the number of months someone's been on a benzo, put that in weeks, and that's how long at least their benzo taper should be. So someone's on benzos for 2 months, taper over 2 weeks. Someone on benzos for 6 months, taper over 6 weeks. Use of benzos for 12 or more months, so the max is generally 12-week taper. So that's how I remember it. So just take the months to weeks up to 12 months. And the reason this is important, we talked about this, but withdrawal symptoms are reported in 44% of patients who have been on benzos for as few as 4 to 6 weeks, but the VA recommends doing a benzo taper if a person's been on benzos for 2 weeks or longer. Another thing to note is benzodiazepine equivalency. So I use this tool from benzo.org.uk. It's a really nice resource when it comes to tapering benzos, and you can find an equivalency. So here is alprazolam 0.5 milligrams is equal to clonazepam 0.5 milligrams is equal to diazepam 10, which is equal to lorazepam 1. And this is important when you're tapering benzos because sometimes you keep the person on the benzo they're on and just taper that over a long period of time. But other times it's preferred to switch them to a longer acting benzodiazepine and then taper that over a period of time, especially if someone's on something like Xanax that has a short duration of action. You might want them on a longer duration benzo to ease them off of it a little bit. It makes it a little easier on the patient. So let's do a tapering example. So we have Jim taking alprazolam 1 milligram 3 times daily for 1 year and wants to stop. How do you taper? So the first things I think about is his total daily dose. So he's on alprazolam 3 milligrams daily. Next thing I think about is what would a 25% reduction be? In his case, 25% of 3 is 0.75 milligrams. And then the final thing I think about is, not the final thing, but the next thing I think about is how is Xanax supplied? So it comes as a 0.25, a 0.5, a 1, and a 2 milligram tablet. So those are the doses I'm going to try to use the most in my taper. You can, of course, cut pills, but it complicates things. And then the final thing I think about is how long the person's been on it. So in this case, 1 year is 12 months. So I want to roughly do a 12-week taper. So let's take a look at the next slide where I just do the taper based on alprazolam. Keep the patient on alprazolam and decrease it. So remember, a 25% dose reduction is 0.75, but I went a little more cautious in this case. So I just went down by 0.5. So instead of being 1 milligram 3 times a day, the patient's now on 1 milligram, 0.5, 1 milligram at night. Then 2 weeks after that decrease, I decrease again, 0.5, 0.5, and 1. You'll notice the night dose is the one that I decreased last because remember, benzos are also sedating. Some are approved for insomnia. They're used for sleep. So I don't want to have the night dose gone and the day dose is still active because then that person's going to be sleepy during the day and not sleepy at night. So as I continue down the dose reduction, I'm then at 0.5. We got rid of the afternoon dose and 1 at night. So this is where I worry about the patient having some like breakthrough anxiety or some symptoms in between their doses because they're used to being on 3 times a day. So this is where a longer acting benzodiazepine would be more helpful. Then I go to 0.5, 0.5, then 0.25, 0.25, and then finally just 0.25 at night and then stop. So remember, our goal was about a 12-week taper would be safe, and we're at 13, so we're right where we need to be. Okay, so next I wanted to give the example of switching to a longer acting agent, in this case diazepam. So we're going to switch from alprazolam 3 milligrams total daily dose to an equivalent dose, which would be about diazepam 60 milligrams. So a 25% reduction of 60 is 15. So instead of going down 15, I'm just going to make it easier based on the dosing forms available and go down 20. So from 60 to 40 total daily dose, and I split it in 2, 20 in the morning, 20 at night to start our taper. Then I'm going to go to 10 2 weeks later and 20 at night. So again, keeping the night dose a little bit higher to help the person sleep. Then 10 10, 5 10, 5 5, 2 5, 2 2, 2 at night, and then stop. What you'll generally see is that The ending of the taper is the hardest part where the person will start to have symptoms. You can generally be a little more aggressive to start, but by the end, depending on your relationship with the patient and if they're filling their meds appropriately and so on, you could extend the taper even longer if need be. But the advantage of the longer acting agent is right off the bat, we're on twice daily dosing rather than 3 times a day. And we're covered. We're covered throughout the afternoon and we're covered overnight with this longer acting agent. Okay, so I talked about some of the issues with benzos, with the addiction component and misuse, but there's also other long-term risks. This study being titled Benzodiazepine Use and Risk of Alzheimer's Disease, Case-Controlled Study. So what this case-controlled study found was that people taking benzos for 3 months or less had no more risk of Alzheimer's compared to the general population. But 3 months to 6 months raised the risk by 32%, and 6-month or longer use of benzodiazepines increased the risk of Alzheimer's disease by 84%. So absolutely like huge implications. So I really don't like long-term benzo use. And it wasn't just this study. Another study found this as well, but longer use of benzos. Another study found that benzo use for more than 3 years and benzos with a long half-life increased the risk of developing dementia. So I think it's really important that we utilize these medications correctly. They can be helpful in the short term, they can be helpful for seizures, for other things, but they're not the best for long-term anxiety control. Next thing I want to talk about with generalized anxiety disorder is diet and exercise. So I am a big fan of therapy. I use medications when need be and when they're helpful, but I also like to focus and highlight on diet and exercise, other things that can be done. So as you would imagine, there's not much funding for these types of studies. So no one's studying if the leafy greens industry isn't studying if that treats anxiety. But there is a little bit of evidence, and I wanted to highlight that. So magnesium deficiency is linked to anxiety. So eat leafy greens, legumes, nuts, seeds. Zinc may lower anxieties, cashews, liver, beef, eggs. Omega-3 fatty acids, salmon, flaxseed. Probiotics may lower anxiety, pickles, sauerkraut, so on. So what you don't see on here is a lot of sugary products, processed food, bread, things like that. So I like to highlight a nice, healthy, high fruit and veggie, protein, that type of diet for people with anxiety. Next is exercise. So something that's often not commonly recommended, but it should be. So this study looked at aerobic exercise, so think of like cardio, like going on walks, runs, treadmills. Resistance training, think of weightlifting, versus no exercise. As you would imagine, both the aerobic exercise and the resistance training help to treat anxiety. So I really like to recommend dietary changes and exercise when people have anxiety. So that summarizes the treatment for generalized anxiety disorder. So first line, CBT, so therapy and SSRIs, and then there's other medications that sometimes fit in too. Pregabalin, buspirone, hydroxyzine, sometimes short-term benzo use, so on. Let's go into panic disorders. So panic disorder, DSM-5 diagnostic criteria is here. Recurrent unexpected panic attacks. And what is a panic attack? It's abrupt, sudden, intense fear, intense discomfort, reaches peak within a few minutes, and then goes away relatively quickly as well. But it's associated with some of the symptoms, are palpitations, sweating, feeling like you're going to die, feelings of choking, chest pain, nausea. So it's really, really serious. I had a veteran when I worked at the VA describe this. One time he had a panic attack in a grocery store and got in the fetal position on the ground. Like that's how severe it was. That's how uncomfortable, how much he thought he was going to die in that moment. That's what he did. He got on the ground in the fetal position. So it's important to really get the symptoms because a lot of times people will describe what they have as panic attacks when they don't really meet the criteria for a panic attack. Next part of the criteria is that after the panic attacks, 1 month or more follows where the person has persistent concern or worry about additional panic attacks, and they take significant changes in their behaviors related to the attacks. So for the example of the vet in the grocery store, he might do anything he can to not go to a grocery store again. order takeout, have someone go to the grocery store for them, and so on. Next, epidemiology, 12-month prevalence, so lower than generalized anxiety, as you might guess, 2 to 3%. Females to males is still 2 to 1. Prevalence in those under 14 is small, and the median age of onset 20 to 24. So there are scales for panic disorder. So use our measurement-based care for panic disorder as well. Get a scale when they first come in, get a score, and then every time you see them, you can update that score to track their symptoms over a period of time. Next is some treatment guidelines. So I have the British guidelines and the Canadian guidelines here. First line, as you would guess, CBT and SSRIs, so it's following a little bit of a trend. Some additional agents, SNRIs, you can use venlafaxine, and then sometimes benzos for short term should be, and then tricyclic antidepressants. If the first line doesn't work, try a different one, a second line, and then for third line, you can do some rarer medications like a second generation antipsychotic or some anticonvulsants. So for a treatment overview, to summarize the guidelines, just like with generalized anxiety disorder, CBT and SSRIs are a good place to start. Second line, you can try a different first line option, sometimes benzos, sometimes some other options. Wanted to highlight some evidence. So this looks at escitalopram in the treatment of panic disorder versus citalopram versus placebo. And one of the things that may be surprising, but maybe not, is that just like how SSRIs take a long time to work for depression and generalized anxiety, same thing with panic disorder. So look at the graph with their symptoms over time. There's a little bit of separation early on, but it's not really until week 8, week 10, where that separation compared to placebo really jumps apart. Next is venlafaxine, the trial on the right. So look at it in comparison to placebo, same thing. Roughly week 8, week 10, you start to see more of that separation. So an important counseling point to your patients with panic disorder is that I know you've been dealing with these symptoms for 6 months, and that's why you have the diagnosis, but it might take a couple of more months before the treatment really starts to take effect. So that's another reason maybe to push therapy or things like that can work more quickly. Next is a Cochrane review. So Cochrane is like a brand name for a meta-analysis. It's a generally well-respected organization that puts together a bunch of studies into one review. And this review here looked at benzos versus placebo for panic disorder. And the thing I wanted to highlight, low quality evidence shows a possible superiority of benzodiazepines over placebo in the short-term treatment of panic disorders. So not like a stellar review of benzodiazepines in panic disorder. Next, let's talk about benzodiazepines a little bit more. Considered second line, should not be used as monotherapy in someone with co-occurring depression. So remember, SSRIs can treat depression and anxiety disorders. Benzodiazepines don't treat depression. They can in fact make it worse. So it wouldn't be a good option in someone who has both of those. Next is, you may be surprised to hear that benzodiazepines have scheduled dosing in panic disorder. So the examples here, clonazepam 0.5 twice a day and alprazolam 0.5 3 times daily. The reason it's scheduled is panic attacks occur suddenly and don't last for very long. So by the time you take an oral benzodiazepine and it kicks in 20, 30 minutes later, the anxiety attack's already over. So taking it as needed, and as needed medication for a panic attack isn't a good option. They simply don't work quickly enough. So the options here are scheduled. So that summarizes panic disorder. So we highlighted again, SSRIs and therapy are where you want to start. And then there's some additional medications that you can use when need be. Final anxiety disorder we'll talk about is social anxiety disorder. DSM-5 diagnostic criteria is where we'll start. Marked fear or anxiety about one or more social situations. Examples include having a conversation, meeting unfamiliar people, being observed while you're eating and drinking. And then some other things related to this. They're afraid that when they do these activities, they'll be humiliated, embarrassed. Their social skills provoke these anxiety, and so on. Final thing is that the duration is also 6 months, so this has to be persistent for it to be a disorder. And the symptoms can be subtle, something like over-preparing for a speech diverting attention to others, or the symptoms can be extensive, not going out with your friends, refusing to go to school, refusing to go out to dinner with people because you don't want people to watch you eating, so on. So this table here kind of just puts the DSM-5 criteria in the symptoms into a more digestible format. So the fears with social anxiety disorder are scrutinized by others, embarrassment, humiliation, some feared situations, public speaking, eating in front of others, use of public restrooms, so on. Symptoms can be relatively mild, blushing, butterflies, but can be severe, tachycardia, diarrhea. And then the types are generalized, so your social anxiety applies to many situations, or it can be non-generalized, like stage fright. I'm perfectly fine in social situations, except for if I have to get on stage, I get really, really anxious. That's a non-generalized social anxiety disorder. 12-month prevalence is 7%. Prevalence decreases with age in older adults, and median age of onset is 13 years old. Onset of social anxiety disorders is sometimes follows or linked with a severely stressful or humiliating event. So someone being bullied, someone forgetting the words during a public speech, someone embarrassing themselves in front of others, something like that. Again, there's a treatment scale. So I love my measurement-based care. So you can get a score when someone has social anxiety disorder when you start to see them, and track their progression over the time that they're with you. Treatment guidelines can be seen here. And there's a nice little pattern that we're forming with our anxiety disorder treatments. So you'll see CBT, SSRIs right at the top of the list. SNRIs are also an option, benzodiazepines you can use, and then you can augment your first-line options. So to summarize the treatment overview, we just talked about it. CBT, SSRIs, second line. You can try a few other things. Final med that I wanted to touch on is a beta blocker as an alternative treatment option. So beta blockers have some evidence, not a ton of evidence, but this study here from the 90s was incredible. I'm surprised that they were able to do something like this back then. But what they did was they gave surgery residents propranolol before performing surgery on people, and they showed that the propranolol helped with their performance. So their hands were more steady, less shake, and they were less nervous. So the propranolol, if it's able to help a surgeon do a surgery better, it's probably able to help someone before they have a public speaking event or something like that. That being said, there isn't a lot of evidence for it, so this is more of a rarer situation. If you look up more evidence, maybe you can choose that for select patients, I guess is what I'm trying to say. So that summarizes social anxiety disorder. So we found that pattern that there's a lot of CBT recommendations for your anxiety disorder, which I think is great, and then there's SSRIs generally as a first-line option. So let's conclude. This table here shows the different first-line options based on the diagnosis. Generalized anxiety disorder, panic disorder, social anxiety disorder. So CBT's first line across the board. SSRIs, first line across the board. SNRIs, depending on the guidelines, first line across the board. And then you get into your agents that are first line for some diagnoses, and then your second line options. Pregabalin, benzos, hydroxyzine for the acute relief, buspirone, tricyclic antidepressants. So anxiety disorders affect millions of people. Treatment generally starts, said it a few times, with CBT and SSRIs, SNRIs, and the use of benzodiazepines should be based on patient-specific factors. My references can be seen here, and thanks so much for watching my presentation.